Good morning, good afternoon. I'm Jorge Pinto from Federal University of Minas Gerais in Brazil. Welcome to the oral abstract session number 2. This session is about the diagnosis, case finding, retention, and viral suppression in children living with HIV. The first abstract presenter is Rhoderick Machekano from Elizabeth Glaser Pediatric AIDS Foundation in the United States. He's going to present the abstract number 7, a validated outpatient department HIV screening tool for children 18 months to 14 years of age, as efficient as index testing in Uganda. Rhoderick, please.
Thank you for the opportunity to present our work on HIV screening tools for children in Uganda. My name is Rhoderick Machekano, and I present this work on behalf of my colleagues. Data from Uganda and other sub-Saharan African countries suggests that HIV case identification and linkage to treatment for children and adolescents lag behind that of adults. Identification of HIV-infected children presents a huge financial challenge. Because of the low HIV prevalence in children, large numbers of children must be tested in order to identify those living with HIV. In 2019, 61 children needed to be tested to identify one HIV-positive child in OPD, compared to 31 children tested to identify one HIV-positive child through index testing in Uganda. After reviewing the literature on HIV in children and screening tools, we developed and validated an HIV screening tool for children to optimize HIV testing resources and provide targeted testing. Our study was performed in 2 phases. In phase 1, we targeted to enroll at least 60 HIV-positive children. And in phase 2, we targeted to enroll 112 HIV-positive children. We screened and tested a total of 3,482 children between 1.5 and 14 years old. 55 children tested positive. The best predictive tool was based on mother's non-HIV positive status or any 2 of the following symptoms. Maternal HIV positive status was automatically included in the screening tool. Using variable selection methods, we selected the subset of questions with the best predictive accuracy from a set of all possible combinations. The 5 symptoms that were included were child sick in the last 3 months, child has recurring skin problems, child had lost weight, child not growing well, and child had a history of TB. This screening tool had an overall sensitivity of 83.6% and 62.5% specificity, meaning the tool correctly identified 83% of HIV positives and 62% of HIV negatives. Among those indicated for testing by the tool, 3.4% were actually positive. In the validation study, we screened and tested 11,342 children under 15 years old. 115 children tested positive for HIV. Of note, 46 of the HIV positive children had maternal HIV status reported as negative or unknown. The tool had an estimated sensitivity of almost 88% in the validation sample. Estimated specificity was 62.6%, consistent with the specificity observed in the developmental sample. The estimated number of children needed to test to get one HIV-positive child when using the tool was 43. However, when we examined the performance of the tool in the OPD children only, sensitivity was similar, estimated at 88.1%, but specificity was slightly improved at 69%. The number needed to test to get one HIV positive in OPD was significantly lower at 28 compared to 43 for both OPD and OVC. Because of the low prevalence of HIV in OVC, the diagnostic estimates have lower precision in the OVC sample. In conclusion, this screening tool has high sensitivity and specificity compared to other tools in the region and can focus testing resources on children more likely to have undiagnosed HIV. Our screening tool significantly reduces the number needed to test to identify one HIV-positive child in OPD, from 61 under current testing algorithms to 28 with using the screening tool. Targeted OPD testing of children using the screening tool is as efficient as index testing in Uganda. Including symptom screening for children of mothers with negative or unknown HIV status prevents 68% of unnecessary tests. Given the low positivity rate in the OVC population, the utility of the tool in this population needs further investigation. The tool has now been incorporated into the Uganda National Guidelines on HIV testing of children. This study was a result of strong collaborations between these partners and was supported by PEPFAR. We thank you.
Thank you, Dr. Machekano. The next presenter is Ms. Vinie Kouamou from University of Zimbabwe in Zimbabwe. She's going to present the abstract number 8, Point of Care SAMBA2 versus Centralized Laboratory Viral Load Assays among HIV-1 infected children, adolescents, and young adults in rural Zimbabwe, a randomized controlled trial. Ms. Kouamou, please.
Good morning, everyone. My name is Vinie Kouamou from the University of Zimbabwe, and on behalf of the SIBA team today, I will present to you the topic, Point of Care SAMBA2 versus Centralized Laboratory Viral Load Assays among HIV-1 infected children, adolescents, and young adults in rural Zimbabwe, a randomized controlled trial. We all know that viral load monitoring is critical for viral load suppression and to achieve the third 95 global target by 2030. In addition to viral load monitoring, differentiated service delivery have been developed, implemented, and expanded mostly in Africa to meet the global target for HIV treatment. That's one of the reasons why the simplified amplification-based assay called SAMBA2, which is a new point-of-care semi-quantitative HIV viral load test, was introduced at selected rural hospital in Zimbabwe in February 2018 to address the problem of viral load testing at rural sites. To achieve this, we conducted a randomized clinical trial of viral load monitoring among children, adolescents, and young adults who had been on ART for over a year. Participants were from Chidamoyo Hospital Clinic and from 8 rural outreach sites. Viral load monitoring was done by either point-of-care viral load by SAMBA at the clinic or standard-of-care viral load by Roche at the provincial referral lab. The primary objective was to compare viral load suppression at 12 months between the two arms, and the secondary objective was to determine the rate of drug switching and the rate of drug resistance among the participants. For viral load testing, whole blood collected in EDTA tube was obtained at enrollment 24 and 48 weeks of study. Plasma was harvested and stored at -20 within 6 hours of collection. The sample for standard of care testing were dispatched weekly to the provincial referral lab, while the one for point-of-care viral testing were through an assay within 4 days at the clinic. For standard-of-care viral testing at the provincial referral lab, the Roche assay Cobas Amplopep was used and the result was returned within 8 weeks. For point-of-care viral testing at the clinic, the Samba assay was run for 90 minutes and the results were available to the provider within 72 hours. Differences between the study arms was analyzed using chi-square, Fisher-Exact test, independent t-test. For drug-resistant evaluation, baseline RNA was extracted from plasma and genotyped by Sanger sequencing, and the drug-resistant mutation were determined using the Stanford HIV database. Baseline characteristic at randomization. Altogether, 390 participants were enrolled. The median age of the participant was 14 years. Over half of the participants were female. The majority, 61 participants, were on a NNRTI-based regimen, and only 7% of the participants were immunocompromised at enrollment with a CD4 less than 200. The overall viral suppression at baseline was 80%, and there were no significant difference between the arms. Characteristics associated with viral suppression at baseline. We noted that participants who received care at the rural outreach site were more likely to be suppressed than participants from the clinic. Similarly, participants on an NNRTI-based regimen were also more likely to suppress compared to those on a PI. Viral suppression and characteristics associated with viral suppression at 12 months. A total of 347 out of the 390 participants that were enrolled at baseline reached follow-up at 12 months. The overall viral suppression was 80%. When we adjusted for the 43 lost to follow-up, there were no difference in viral suppression except for adolescents versus children. Only age greater than 10 years and viral load greater than 1,000 copies at baseline predicted virologic failure at 12 months. Since we were assessing the role of a newer point-of-care viral testing at rural, we then analyzed the rate of confirmatory viral testing, test result turnaround time, and drug switching. A 6-month follow-up, among the 69 participants that had a viral load greater than 1,000 copies per ml, 72% had a confirmed viral load test performed. The frequency of confirmatory viral load testing was significantly greater for point-of-care viral load testing versus standard of care. The turnaround time for confirmatory result was significantly shorter by the new point-of-care viral load testing at the clinic compared to standard of care at the provincial referral lab. At 12-month follow-up, a statistically significant turnaround time was observed when confirmatory viral load testing was done by point-of-care viral load testing at the clinic versus standard of care at the provincial referral lab. However, there were no difference in rate of drug switching between the two arms. Genotyping resistant testing was carried out among 24 participants failing on a second-line PI-based regimen. Drug-resistant mutations were identified in 19 of the 24 participants. Resistance to PI was rare and it was identified in only 4 participants. Dual-class resistance to NRTI and NNRTI was detected in 10 participants. Interestingly, after a median duration of 7 years on a boosted PI, resistance to NNRTI was found in the majority, 17 of the participants. In conclusion, point-of-care viral load provided earlier and efficient confirmation of viral load suppression, but with similar results for drug switching. Viral load suppression was achieved in 80% at 12-month follow-up among children, adolescents, and young adults in rural Zimbabwe. Viral load suppression was significantly greater over 12 months in participants in care at the rural outreach site and was less likely among PI recipients regardless of being at the rural outreach site or at the clinic. And because of PI failure, access to integrate strain transfer inhibitor-based steroid regimens are needed to achieve 95% viral load suppression among children, adolescents, and young adults in rural Zimbabwe. I would like to end my slide by acknowledging the study participants and staff, the Chidamoyo Hospital Clinic, and the sponsor. Thank you very much.
Thank you, Ms. Vinie Kouamou. The next presenter is Ms. Anna Tallmadge from Clinical Health Access Initiatives, CHI, in Malawi. She's going to present the abstract number 9, right under our nose, a simple screening tool to identify HIV-positive children outside the PMTCT program at outpatient department in Malawi. Ms. Tallmadge, please.
Hi, everyone. My name is Anna. I'm a program manager at the Clinton Health Access Initiative in Malawi. And over the last 2 years, my team has been supporting the Malawi Department of HIV and AIDS to develop a simple screening tool to identify HIV-positive children between the ages of 2 and 12 years old who are not currently being caught by the PMTCT program. So currently in Malawi, about 1 in 3 HIV-positive children has not been linked to treatment. And we see that pediatric treatment coverage has continued to lag behind adult treatment coverage. So together with our ministry colleagues, we started to really reflect on who these missed children are and how we could go about engaging them in care. We know that Malawi already has a very strong PMTCT program and that linkage of known HIV-positive children is high. So we suspected that the majority of these untreated children are actually undiagnosed, either because they had been infected postnatally or because they had defaulted from care. So the nuance there is that we think this is primarily an identification problem rather than a linkage problem. And so if we set up systems to diagnose these remaining children, that would effectively close the pediatric treatment gap. So next, we started to consider where we would go about looking for these undiagnosed children. In Malawi, data suggests that children in this age group do have frequent contact with the health system. So that means they are present in health facilities and available for testing. We just had to figure out how to go about testing them. So our first option would be just to test all children at health facilities. But we ruled that out pretty quickly because there are insufficient resources to implement universal testing. And regardless, it would be very inefficient since prevalence in this population is so low. So if we're going to target testing, one option is to test all sick children. However, the sensitivity of this is also low since there are so many factors in general childhood illness. And additionally, by the time a child starts manifesting clinical symptoms of HIV, that's often pretty late into disease progression. And ideally, we'd want to identify these children earlier. So a third option would be to introduce a screening tool. And this certainly seemed more feasible than universal testing. However, we had a negative conception that screening tools are usually pretty difficult to use and fairly time intensive. And additionally, most of the tools we've seen are based on reviewing constitutional symptoms, which is also not a very sensitive indicator for HIV in a setting like this. But as you may have guessed, we did proceed with option number 3. And in doing so, we tried to commit ourselves to creating a screening tool that was not only effective, but also fairly simple, easy to use, and quick to administer. So as we started to develop this tool, we realized there was an opportunity to approach screening in this age group in a very different way. Because the thing is, the primary risk we have to assess in this age group is maternal exposure. So in our view, once a mother has been confirmed HIV negative at the end of breastfeeding, there's very little HIV risk for the child until such time that they initiate sexual activity, which surveys suggest is around age 13. So for this age group, we hypothesized we could screen children simply by reviewing their mother's testing history. So the screening tool we ended up developing is formatted as a simple checklist. Essentially, every time a child between 2 and 12 years old presents to a health facility, the screening personnel completes a new screening slip. So first, you'd start with a review of the mother's testing history, either by looking at her patient card or by taking a verbal report. You'd check off the applicable testing history, and the tool would send you down a series of pathways with customized decision trees. So essentially, the screening tool is seeking to confirm that the mother was HIV negative at the end of the breastfeeding period, thus ensuring that mother-to-child transmission risk is known. If the mother's status had not been confirmed since the end of breastfeeding, she's referred in directly for HIV testing, and if she tests newly positive, her children are also screened in. The tool also has provisions for if the mother is deceased or absent that day or previously known positive. We piloted this tool last year and collected over 8,000 screening slips for review. And this provided some really interesting and detailed findings, which are summarized here. But for the sake of time, I'll point to just two key takeaways. So firstly, we see that about 1 in 4 mothers did not have a confirmed HIV status since the end of breastfeeding. So these mothers were referred for same-day testing, and of those who accepted, 1.9% tested newly positive. Children were referred for testing when they had defaulted from care, or the mother's status could not be determined, or their mothers had tested newly positive or inconclusive that day. So with these criteria, just 8% of total children were referred for testing. And of those who tested, 3.9% were diagnosed newly HIV positive. So we view this as a very compelling result because we were able to target testing in such a way that only the children who could have had maternal exposure are referred for testing. And in doing so, we did effectively identify new diagnoses at a yield rate that far exceeds the national average in this age group. So overall, we found that this tool effectively identified mothers and children who were eligible for HIV testing, and it did so by promoting efficient pediatric testing without posing a strain on resources or healthcare worker time. This style of screening is very intuitive, and we saw that it effectively complemented the strong PMTCT program by putting focus on filling the gaps in our existing interventions. So please feel free to contact me at the email address provided at the bottom of this slide to discuss further. But otherwise, thank you so much for listening.
Thank you, Anna. The next presenter is Megan Gleason from USAID in the United States. Abstract number 10, Finding the Remaining Unidentified Children Living with HIV, Opportunities Through Index Testing. Ms. Gleason.
Hello, my name is Megan Gleason. Today, I will be presenting Finding the Remaining Unidentified Children Living with HIV, Opportunities Through Index Testing on behalf of my other USAID Office of HIV/AIDS Division of Prevention Care and Treatment colleagues, Dr. Meena Shrivastava, Dr. Lana Lee, and Dr. Anouk Amzal. Thank you to the International Workshop on HIV Pediatrics and to the conference coordinators for the opportunity to present. The authors of this presentation have nothing to disclose. This presentation was made possible by the support of the American people through the United States Agency for International Development, USAID, under the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. The views of this presentation are those of the authors and do not necessarily represent the views of USAID, PEPFAR, or the United States government. Index testing is an efficient and effective way to identify PLHIV and quickly link them to life-saving ART. Unfortunately, index testing has been slower to scale for pediatrics than it has for adults, and more efforts are needed to maximize this testing modality to close the gap in case identification for pediatrics, or the first 95 of UNAIDS 95-95-95 goals. In this analysis, we sought to better understand the index testing gap by estimating the number of biological children less than 15 years of age that could be tested and subsequently identified if all women living with HIV, or WLHIV, 15 to 49 years old on ART, not yet indexed, were offered and provided index testing services. We used PEPFAR program data, total fertility rates, and age-adjusted fertility rates as determined by DHS, the Demographic and Health Survey, and UNAIDS AIDS Info 2019 results. We analyzed data from 23 PEPFAR-supported countries identified here. Our first step in the analysis was to reveal the significant gap in WL-HIV on ART offered index testing through the use of PEPFAR program data. We found that only 38% of WL-HIV on ART have actually been offered index testing, leaving a gap of over 4.8 million women who could benefit from index testing. Next, we applied total fertility rates of each country to the WL-HIV on ART gap to estimate these women may have 33,209,196 biological children that could be elicited for testing. We then applied each country's pediatric testing yield, the results from fiscal year 20 Q3 PEPFAR data, which range from 0.9% to 9.5%. This gave us an estimated total of 1,520,259 biological children of these WL-HIV on ART who could possibly be identified as a child living with HIV or CLHIV. However, because the total fertility rate is the number of children born to a woman over her entire lifetime, we adjusted our calculation using age-specific total fertility rate. This takes into account younger women who do not have as many biological children as older women. This adjustment then estimates 762,234 CLHIV could be identified. We then adjusted our calculation again to account for under 5 mortality and HIV-related mortality, as we know children die before testing, diagnosis, and linkage to ART. This adjustment revealed the final estimated number of biological children of WL-HIV on ART that could be identified as CLHIV as 513,215. We then compare this final estimation to UNAIDS' estimated treatment gap in CLHIV. UNAIDS estimates about 609,320 CLHIV in these 23 countries have not yet been diagnosed. Compared to our estimate, we see that there's potential to identify up to 84% of these yet to be identified or diagnosed CLHIV through index testing their biological mothers who are HIV positive already on ART. In conclusion, by using our gross estimate approach, we estimate index testing has the potential to identify 513,215 children and greatly improve the treatment gap for CLHIV globally and increase the number of children on ART by up to 50%. There are several limitations to this analysis listed here. In the interest of time, I will not review them all in depth. However, the authors are taking these limitations into consideration as we continue with next steps on this analysis. We understand that with more granular data, we can have an even more refined prediction of the index testing gap for CLHIV. We recommend that implementing partners supported through USAID PEPFAR should conduct a baseline chart review to identify the current index testing coverage of all WL-HIV on ART and identify which WL-HIV on ART have children with unknown status. We then encourage that there is immediate testing and prompt linkage to ART for any newly identified CLHIV. For next steps, the authors will continue to refine this analysis to reflect an even more accurate estimate of the opportunities that index testing has in closing the first 95 gap for children living with HIV. Thank you for your time.
Thank you, Megan. The next and last presenter for this session is Dr. Agnes Langat from Center for Disease Control and Prevention in Kenya. And she's presenting the abstract number 11, Factors Associated with Late Presentation of HIV-Infected Infants for Early Infant HIV Diagnosis Service in Kenya.
Greetings to all of you. My name is Dr. Agnes Langat, and I will be presenting on factors associated with late presentation of HIV-infected infants for early infant HIV diagnosis services in Kenya. Progress to decrease infant HIV infections have stalled, and yet the scale-up of early infant diagnosis (EAD) is one of the main priorities for countries aiming to achieve elimination of mother-to-child transmission globally. Some of the countries under the global plan only achieved around 50% testing coverage among the exposed infants in 2016, and by 2018, coverage had only increased to 68%, as shown on the second bar graph. Kenya is among the 21 priority high HIV burden countries targeted to ensure global epidemic control. We have an estimated 69,000 HIV-infected women in need of ART, whereby our current MTCT rate is at 10.8%, and this is still very high. But despite efforts to scale up EAD, only 69% of the HIV-exposed infants born in Kenya by 2019 received HIV testing within the first 8 weeks of life. Our annual target is about 80%, so we're way below that. Recent studies in Kenya still show that in some areas, 51% of HAES received their HAES services at some point in their life, but a quarter still failed to receive their first test before the 8 weeks of age, and this is contrary to the Kenyan guidelines. We therefore set to try and assess the factors that are associated with late enrollment into HAES services for the HIV-infected infants in sites that are supported by PEPFAR. This was a cross-sectional study that was done between October 2016 and September 2018. We collected data from routine clinical documents like PCR log registers, the HAE-exposed infant registers or cards, the antenatal registers for the mothers and their clinical cards or any maternal medical records. We looked for the association of baseline characteristics to timing of HAE enrollment using logistic regression. The definitions that we used: late HAE enrollment was defined as any PCR testing done after 8 weeks of age from the time of birth. Maternal ART start date, and we used as a proxy for time of maternal HIV diagnosis, since we did not have the actual HIV diagnosis in the records. And for the mothers who were diagnosed for the first time in MCH, they were referred to as newly diagnosed HIV patients. And for those who had had a test prior to this birth, they were referred to as known HIV status. So, looking at the results, who are the infants who are more likely to test HIV positive? Of the 4,011 HIV-infected infants who had the date of birth recorded, we found that 67% of them enrolled late for EAD services after 8 weeks of age. The median infant age at diagnosis was around 13 weeks, with a very wide interquartile range of 4 weeks to 64 weeks. This just showed that they had late access to PMTCT or HAES services. Looking at the mothers, who are the mothers who are likely to be transmitting HIV? First, looking at among all the infants, the 4,000 infants, 60% of the HIV positive infants were born to newly HIV positive mothers, newly diagnosed mothers. Secondly, we looked at the mothers of the HIV positive infants who enrolled late, and this were the 2,669 infants, and we found that 51% of them were born to young women aged between 24 and 34 years. 46.7% did not attend ANC. 64.5% were newly diagnosed HIV positive mothers, and 60.5% were initiated ART at postnatal period. Looking at our multivariate analysis, what we found were the factors that were independently associated with late HAE enrollment were lack of maternal ANC, new maternal HIV diagnosis, lack of maternal ART with adjusted odds ratios of 1.54, 1.38, and 1.96 respectively. However, HAE identification in the outpatient had an adjusted odds ratio of 14.2 and 8.92 in the inpatient. This outpatient or inpatient, this is where the infants were presenting for the first time or they were being captured for testing, having either been missed in the MCH clinics or were presenting for the first time in the outpatient because of seeking other medical services. In conclusion, therefore, what we are saying is that, first, a HIV-infected infant means that there's something in the PMTCT cascade of care that we have missed, a missed opportunity. 2, we need to identify the HIV-positive mothers early by advocating for early ANC services for the moms and therefore, and hence early EID services for the infants. 3, routine HIV screening in OPD and inpatient setups will help to identify the infected infants who may have been missed in the MCH clinics or presenting for the first time. I would like to acknowledge the Ministry of Health staff at the PMTCT facilities and the PEPFAR implementing partners who are supporting these facilities. Thank you for listening.